The 44th Annual Conference of Pakistan Association of Pathologists and 9th Joint Conference of Societies of Pathology. Today's the first scientific session is being chaired by Dr. Shahid Parvez and Dr. Humaira Nasir. I invite Major General Hafiz for a welcome address.
Assalamu alaikum. Dear Dr. Shahid, President, Pakistan Association of Pathologists, Dr. Mulazam Bukhari, President-elect, PAP, Dr. Asif Loya, Chairman Organizing Committee, esteemed colleagues, and the promising future generation of our histopathologists. Greetings to everyone. It's a moment of great pride for me to stand before you today. Our society, Histopathology, Cytopathology Society of Pakistan, which was established in 2010 in this very city, has now grown to approximately 200 members up till now. And it continues to expand. As we have gathered here for this conference, I, along with Dr. Nasser from AKU, Dr. Imran Nazir and Dr. Zafar from Shifa International Hospital, after thorough deliberations with our seniors like Dr. Shahid Parvez and Dr. Sajid Mushtaq, have crafted a meticulously extensive scientific program after thorough deliberations and input from these. During the preparation of this program, we were fortunate to have valuable insights and guidance from Dr. Sajid Mushtaq, to whom we have requested to deliver a lecture on IDH wild-type gliomas. Our heartfelt thanks extend to our beloved expat Pakistani consultants, especially Dr. Shafiq, Dr. Mariam, and Dr. Khalid Amin, who have traveled all the way from UK and USA at their own expenses to share their experiences and wisdom with us. Dr. Khalid Amin have already conducted a very useful half-day workshop on EUS FNS cytology yesterday. And Dr. Shafiq Gill and Dr. Mariam will be carrying out a FRC PAT mock exam after this conference as well. This conference featured in-depth discussions on significant areas like breast pathology, female genital system, neural tumors, endocrine tumors, hematolymphoid pathology, bone and soft tissue sarcomas, and neurodegenerative disorders with a special focus on demyelinating diseases. Additionally, we have invited an expert, Professor Dr. Hans Lasman from Vienna, Austria, who is an expert on non-tumor CNS pathology, and he will be available on Zoom tomorrow to shed light on the challenges being faced in interpretation of brain biopsies in suspected cases of inflammatory demyelinating diseases. Due to time constraints, we would kindly request our speakers to adhere to the allotted time slots, and interactions during the refreshment breaks may be utilized for clarification or any question answers. I would like to take advantage of this opportunity to extend the appeal to increase the membership of this society. At present, we have around 65 life members and around 130 to 135 annual members. And I would request all the HODs and consultants that they should request their colleagues to become members of HCSP, and their trainees should be encouraged to become associate members. In the end, I would like to extend my gratitude to the organizers, Dr. Asif and Dr. Umar Chuktai and their dedicated team, as well as the sponsors, without whom tireless efforts and sponsorship, this conference would not have been possible. Thank you very much.
Thank you so much, sir. Now I will invite Dr. Khalid Amin, who has joined us from USA, and he will be discussing spectrum of serrated changes in inflammatory bowel disease.
It is my honor to be here today, and I really thank the committee members who have invited me, and it is a great honor. Um, so I will. I have no disclosures, no financial any disclosure, but there's one disclosure I will make. What I'm going to present today, I didn't know about it until recently. And what inspired me was a recent paper that Dr. Elizabeth Montgomery, as you all know, she's one of the uh, key or one of the really well-known GI pathologists. She wrote a recent paper on the serrated lesions, and it was very inspiring. I do mostly GI pathology, so there's a lot of things I didn't know about it. And I read, and I read some additional papers, and I said, okay, this is something that we need to I need to educate myself and others. And when Sir Fees invited me, I said, okay, I'm going to do this topic. Okay, here are the aims and objectives of my talk. I will start with a brief review of the risk factors for colorectal cancer in IBD and the surveillance guidelines. I will also briefly discuss the non-conventional dysplasias in IBD. But the main focus of my talk will be discussion on serrated lesions, where I will discuss the morphological criteria, the classification and nomenclature of these kind of novel, lesions. I will also present data from some of the studies, especially molecular studies and some studies that have looked into the risk of these lesions for the development of colorectal carcinoma. And last, I will briefly talk about future directions and recommendations. So as we all know that IBD has increased risk of colorectal carcinoma. If you look at the literature, there are many different risk factors that have been identified. But one of, in a very recent large meta-review that was published by a Dutch initiative of Crohn's and colitis, it's a really nice review, and they actually mentioned 13 risk factors. Here are some of the important ones. And, as we all know, one of the most important risk factors that is for the development of colorectal carcinoma and IBD is actually dysplasia, and that is one of the reasons that we do surveillance biopsies. Colonic strictures, inflammatory pseudopolyps, and PSC, they can be considered as second-tier risk factors. Increased extent of the disease, although it conveys modest risk, it has the strongest evidence that it is one of the key risk factors based on several studies. Also, increased inflammation, whether seen by endoscopy or histology, is also an important risk factor. In the literature, actually, there are certain factors that have been found to be productive, and these include basically aminosalicylic acid or use of mesalamine, thiopurines, increased surveillance, statin use, and interestingly, smoking. But the role of smoking is controversial. Some studies have negated this. The overall risk factor for colorectal carcinoma in IBD is estimated to be 3 to 5%. And this risk actually increases with time. With increased duration, there's increased risk. And the degree of this degree of increased estimated risk, it varies among different studies, and this is based on different methodologies that were used in these studies and the patient selection bias. But it is estimated that, and this is again some of the older studies that were done, they have estimated that the risk is up to 2% after 10 years, and it increases all the way to 18% after 30 years. Some of the more recent studies have actually much lower risk, and this is because of the new treatment options that are now available, and also due to increased surveillance and increased surgical intervention. So due to this increased risk, the American Gastroenterology Association recommends that IBD patients should have surveillance colonoscopy biopsies every 1 to 3 years with careful inspection and extensive biopsies of all anatomic segments of the colorectum. So dysplasia on endoscopy, it can be invisible or it can be visible. According to the 2015 scenic guidelines, um, if colonoscopists, if they see a visible lesion, they will take a biopsy, and if it turns out to be dysplasia, then it is recommended that it should be completely excised. They also recommend or they endorse the use of advanced colonoscopy techniques such as chemoendoscopy. Also, they recommend that if high-grade dysplasia is seen in non-targeted biopsies, then you should really think of doing colectomy. And recommending colectomy for these patients with non-visible dysplasia is based on very strong grade A evidence that colectomy treats undiagnosed synchronous colorectal carcinoma and prevents metachronous carcinoma in such patients. So the development of colorectal carcinoma in IBD patients, it follows the inflammation, dysplasia, and carcinoma pathway, as opposed to adenoma carcinoma pathway that is seen in sporadic colorectal carcinomas. And as we know that surveillance biopsies are done for this, and one of the important jobs for us as a pathologist is basically to determine whether there's dysplasia or not. And that that task can be really, that task actually can be quite daunting because as we all know that the reactive changes that can occur with severe active disease can result in a lot of architectural and epithelial atypia, and that can make things really difficult. And also, because of the new recommendations, if there's a high-grade dysplasia, and if it is from an invisible or non-targeted biopsies, the patient can end up having a colectomy. So therefore, the burden on the pathologist is a lot. So the dysplasia can be visible. It can be, the visible dysplasias can be polypoid. And the polypoid lesions can be sessile or pedunculated, or it could be flat, such as superficially elevated or depressed. And invisible dysplasia is when it is identified in random non-targeted biopsies. If there is a visible lesion that turns out to be a positive for dysplasia, then the recommendation is complete excision. However, if dysplasia is seen on non-targeted biopsies and it is invisible, then it has real serious consequences. If it is called indefinite for dysplasia, then it depends whether we favor dysplasia or favor benign. If it is favor dysplasia, then recommendation is surveillance for after 3 to 6 months, and if it is benign, then after 6 to 12 months. Low-grade dysplasia, again, it's it is sometimes colectomy is done, and most of the time there's increased surveillance that is recommended for low-grade. But for high-grade, again, it is recommended that if you see high-grade dysplasia in random biopsies, colectomy is what is recommended. So most of the dysplasias that we see are conventional dysplasias, and this is something that we have all been trained, and it's not, although it is challenging, but this is something that we have seen and we have been trained, so we know about it. But recently, there were certain studies that have come out that have actually shown that there are these unfamiliar type of dysplasias that are collectively called non-conventional dysplasias. And these dysplasias actually have shown to have distinct morphological, clinico-pathological, and molecular features compared with conventional dysplasia or sporadic adenomas. A significant proportion of non-conventional dysplasias are endoscopically flat or invisible, and at least some of them appear to have higher malignant potential than conventional dysplasia or sporadic adenomas. Colorectal carcinoma occurring in patients with non-conventional dysplasia are more likely to be high grade, poorly differentiated. So that is why familiarization with these unfamiliar types of dysplasia is really important. There are, in a recent, actually there have been some recent papers, and there are at least 7 different types of non-conventional dysplasias that have been reported. The 3 dysplasias with serrated morphology I will discuss in more detail, but I will briefly discuss these 4 types of dysplasias, non-conventional dysplasias. The first is the hypermucinous dysplasia. This is, it constitutes about 2% of all, dysplasias, and it is seen more in patients with ulcerative colitis. And these patients have very long duration of the disease, actually, according to some studies, more than 20 years. And it is associated with PSC. Histologically, it has a tubulovillous architecture, as you can see over here. And these villi, or this expanse, is actually lined by cells that show very hypermucinous change. At the base of these, you can see cells that have kind of low grade, but as it matures, the atypia goes away and the cells are mostly hypermucinous. That's why if you take superficial biopsies from this dysplasia, it can be really hard. This type of dysplasia, although it looks pretty bland, it is a high risk. It has a high risk behavior, and therefore, because a lot of times you will find high-grade dysplasia in these associated with this type of dysplasia. Next is the crypt cell dysplasia. It is also not that common, and it is also seen more in patients with PSC. And again, these patients also have a long duration of the IBD, more than 15 years. And it is characterized by this change that occur within the crypts. It is not occurring at the superficial portion of the mucosa, but only in the crypts. And it is characterized by, as you can see, very hyperchromatic cells. These are slightly enlarged. There's a little bit of overlapping, and they have oval to slightly elongated morphology. You can actually see mitotic figures. Interestingly, in dysplasia, this type of dysplasia, there's not much inflammation. And this is also considered as high risk. Next is dysplasia with increased panel cell differentiation. And this actually is one of the most common type of non-conventional dysplasia, and it is histologically, it is defined by presence of increased number of goblet cells. You should see it at least in 2 consecutive crypts and in 2 different foci. This, and also if you look at the overall morphology, it has a tubular morphology, where the cells appear low grade, and they are present both at the crypt and also at the superficial surface. This is a low risk type of dysplasia. Next is the goblet cell deficient dysplasia, and this is characterized by a near absence of goblet cells, as you can see over here. And due to absence of this goblet cells, the remaining cells, they have a very eosinophilic cytoplasm, and you can see sometimes eosinophilic secretions. And also this imparts a tubular morphology. Again, these pencilloid, low-grade type of cells are seen both at the crypts and at the surface. This is also considered a high-risk dysplasia because in 40% of these cases, there's an associated high-grade dysplasia. Okay, now coming to the main focus of my talk. So the serrated IBD-associated lesion, they can range from insignificant superficial hyperplastic changes to severe complex form of dysplasias. So these are the 4 lesions that I've mentioned over here, and this is what was recently described in the paper that I mentioned earlier by Dr. Elizabeth Montgomery and their group. And they found that these have distinct histological features. They have also very characteristic molecular profile. Although they can be challenging, but if you know the subtle features, you can distinguish between these lesions. So I'm going to start with serrated epithelial change. To give you a historic perspective, the first attempt at standardization of nomenclature for reporting conventional dysplasia was published in this paper by Dr. Riddle et al. In 1983. And this was done to help to basically provide guidance for risk assessment and for treatment. In their paper, actually, they did not mention the specific serrated epithelial change, but they did mention that there is this unusual type of serrated changes, but they didn't know what to do, and they said it's best to classify it as indefinite for dysplasia. It was not until year 2000 when some sort of a definition for serrated epithelial change was introduced. The first paper that that came out by Kilgore et al., they called this as hyperplastic-like mucosal change, which is basically characterized by diffuse expanse of flat mucosa that appear like hyperplastic colorectal polyps, and it was composed of cells, very bland appearing cells with basally located nuclei and an apical distended cytoplasm, which was distended with mucin. It was not until recently when the term serrated epithelial change was adopted. And some of these papers that I've shown here, they actually characterized this, they gave a more definitive definition of this change, and they also looked into the risk assessment, and they did also some molecular testing was done on these lesions. So based on these studies, some of the clinical pathological characteristics that these patients have are listed over here. These patients are typically in the 5th or 6th decade. They have long-standard IBD, mean 16 to 18 years. Half of the SEC patients have extensive disease. And on endoscopy, they have moderate to severe activity. And on histology, they show typically acute inflammation. Another feature of this type of change is that it is often invisible. So one of the large studies that was done in Johns Hopkins showed that only 18% of SEC detected were targetable visible lesions. The study by Mayo showed that 38% of the SEC lesions were visible. The numbers are higher in the Mayo studies because in more than 50% of their cases, they used enhanced techniques such as chemoendoscopy. So as I told you, the definition of SCC has not been consistent in literature. It was first described as hyperplastic-like change. Johnson et al. In 2014 mentioned that you should see serrations that should only be seen in the upper half of the crypts. But the most comprehensive definition of this change was actually described by Dr. Elizabeth Montgomery et al. In their group in a recent publication. And that is what I will discuss in my next couple of slides. So here are the images of serrated epithelial change. First thing that you should note is that there is very, very significant crypt architectural distortion. So that is the first thing that you need to note. Massive crypt architectural distortion. Secondly, you will see that the perpendicular orientation of the crypts is lost. The crypts are going in different directions. So that is another important feature. Thirdly, there is quite a bit of inflammation that separates the basis of the crypt from the muscularis propria. That's another feature to look for. Also, if you look at the serrations, these serrations are actually irregular, and they are present both in the crypt or base of these crypts and also superficially. And also, there are a number of goblet cells. So this type of dysplasia, you don't lose goblet cells. Actually, they will be abundant. And also, if you look at the nuclei are rather bland. They are not hyperchromatic and basally located. So here is another example. You can see massive crypt distortion, and the arrows over here actually indicate presence of goblet cells. And in this image, image D, you can see that there's high-grade dysplasia occurring on top of serrated epithelial change. Okay, so another thing I want to tell you about this is do not confuse the superficial hyperplastic changes that are very commonly seen in IBD with SEC. I have made this mistake actually. So the superficial hyperplastic change, first of all, it will keep its, the crypts will keep their perpendicular orientation. As you can see, all the crypts, their bases are almost touching the muscularis propria. So these are the two important features. And the serrated changes are only seen in the superficial regions of the crypt. Another thing that, another entity that you have to, differentiate SCC is hypermucinous dysplasia, as I mentioned earlier. Actually, the hypermucinous dysplasia, the cells have the appearance of a gastric foveolar type of cells. And if you look overall at the lesion, it looks like a low-grade mucinous neoplasm. So here are two images. One of it is SEC and other is hypermucinous. And as you can see, they almost look similar. But there is a subtle feature that you have to look for, and that is presence of hyperchromasia, which is seen in this image on the left. So this is the feature that you will see in hypermucinous low-grade dysplasia, and it will be absent in SEC. This is an example of hypermucinous dysplasia with high-grade dysplasia and an intramucosal carcinoma. So now we have discussed the histological features. Next, what does it imply? What kind of risk does these type of lesions they convey? So there are several studies that has been done. The Kilgore study that initially described this, they only saw it actually in Crohn's disease patients. They had 10 patients of Crohn's disease with colorectal, 30 patients with colorectal carcinoma and 30 patients without colorectal carcinoma. And they found that about 33% of their SCCs were seen in Crohn's disease that is associated with colorectal carcinoma, which was significantly higher than the other control group. The study done by Parian showed that about 39 of their 187 patients with IBD and SCC had synchronous or metachronous dysplasia or colorectal carcinoma. They also found out that this SCC and dysplasia or colorectal carcinoma was present in the same location. So there was a 68% location concordance in their study. But one of the main drawbacks of this study was that it did not have a control group. The study by Johnson et al. From Mayo in 2014, their results were not that exciting actually. So they found 79 cases of SCC in over 4,000 patients of IBD. And they found out that in patients without SCC, after 1 year, they found that 4% have colorectal neoplasia as opposed to IBD with SCC, the number were 12%. And after 3 years, it increased to 30% and 9% respectively. This difference was actually significant by univariate analysis, but by multivariate analysis, it was insignificant, probably because the patients with SCC had much more frequent colonoscopies. Okay, so this is another very nice paper that came again from the Dr. Elizabeth Montgomery's group, and they looked into the molecular landscape of these serrated lesions. For SCC, they did NGS, and they divided their cohort into actually 3 groups. They had 10 normal cases where no mutations were seen. They had 10 patients with SCC without any associated other type of dysplasias. And in this group, they found that 50% have T53 mutations. And an additional 2 cases have KRAS mutation on top of TP53 mutations. 5 patients were negative. Now the group that where SCC was seen in association with other types of dysplasias, the incidence of mutations was much higher. With low grade, it was about seen in 71% of the cases. With high grade, 83. And in all cases of adenocarcinomas, they found mutations in the TP53 gene. So this was a very significant, powerful study that demonstrates that probably these lesions have very unique molecular profile. And also, they went ahead and they also did mutation analyses on the dysplasias that they saw associated with SCC. And they found that the low grade and the high grade and the colorectal carcinoma also showed the same TP53 mutations. So basically, in order to, for us to actually report this entity, and in order to basically determine the strength of this histological definition, what is needed are more inter-observer reproducibility studies so that this established definition can be applied uniformly in routine practice. And also, additional studies need to be done to estimate the risk of progression to dysplasia and colorectal carcinoma in patients with SCC. And these studies should have control groups with them. So although the clinical implications of these lesions are not still fully elucidated, pathologists still mention SCC in their final diagnosis as it is often seen in association with dysplasia and neoplasia. Up till now, there are no high-level or high-quality evidence that are over there for us to, to guide us of how to follow these patients. But the gastroenterologist, the way they manage it is that they completely excised any visible SCC lesion. And I will tell you, I already mentioned that I made a wrong diagnosis, and I mentioned serrated epithelial change in my report. And the gastroenterologists, they kept on bugging me. They said, okay, do we have to bring the patient back in 6 months? What do we need to do? And they were actually doing colonoscopy every 6 months to 12 months. So what is typically done is that these visible lesions are removed and extensive sampling of the non-visible lesions are done and with more frequent monitoring. So if you see something, if you see this serrated epithelial change and it fulfills this criteria, you can call it serrated epithelial change and put this recommended comment that serrated epithelial change can be seen in long-standing inflammatory bowel disease. Some observers regard these changes as equivalent to indefinite for dysplasia. Okay, next I'm going to discuss sessile serrated lesion-like changes and sessile lesion not otherwise specified. So SSL-like change, it has morphology which is similar to what we see very commonly, the sessile serrated adenomas in non-IBD patients. The sessile lesion which is not otherwise specified are serrated lesions without definite SSL-like or TSL-like features. So what you need to see in these is that you have to see a serrated architecture that is prominent either on the mucosal surface or at the base of the crypt. And there should not be a lot of goblet cells as opposed to SCC, which shows a lot of goblet cells. There should be no ectopic crypts, elongated pencillate hyperchromatic nuclei, which are typically seen in traditional serrated adenomas. And also you need to see microvesicular cytoplasm. And typically these lesions are villous or bulbous in architecture. So here is an example. You can see that this is a kind of a bulbous and villous lesion. It has serrations that are regular. Crypts are widened at the base. You can see a few L-shaped crypts with lateral growth. And in this high magnification image, you can see the microvesicular cytoplasm and very few goblet cells. And the nuclei are small and lack an overt atypia. Here's another example. Again, you can, in image A, you can see the villus and bulbous architecture. In image B, you can see the serrations that are limited only at the superficial end. Image C shows some of the crypts that have very few goblet cells, and in image D, you can see that there is low-grade dysplasia. So the same paper that I referred earlier, they also did molecular testing on these type of lesions, and they found, interestingly, that in 11 of their cases of SSL-like or SL not otherwise specified lesions without dysplasia, they found KRAS mutations in 9 out of 11 patients. And they found BRAF mutation in 1 patient. And in one of the KRAS mutation patient, they also saw a GNAS mutation. They have only 2 cases where they saw both these lesions and associated low-grade dysplasia. And both of these cases showed KRAS mutations. And 1 case also showed additionally a TP53 mutations. So, so these results clearly indicate that this lesion is different from what we saw earlier, the SEC, because they have a very different molecular signatures. This is another study that was done a little bit earlier on serrated colorectal polyps. And in this study, actually, they did not, at that time, this was probably done in 2015. The definition of SCC or SSL-like lesions was not that clear. Anyhow, they included, the cases that they had. I want to actually highlight this group with, which was serrated polyps without any negative, which were negative for any associated dysplasia. And in this group, they found that 15 patients, or 65% of their patients, have BRAF mutations, and 4 patients have KRAS. So these type of serrated polypoid type of lesions, they have, a higher incidence of BRAF and KRAS mutations. So as opposed to, so the polyps, the sessile serrated adenomas or lesions that are seen in non-IBD patients, the primary mutations that are seen in this are basically BRAF. So, which is different because, the studies I showed you earlier, many of these serrated lesions actually showed KRAS mutations. So a lot of, we need to look into this, like how do these differ from their non-IBD counterparts. To give you an estimate of how common these lesions are, Lee et al. Actually found only 4 out of their 78 cases that have the SSL-like or SLNOS type morphology. And the study by Choi et al. Found only 5 cases. One was out of their 106 dysplastic lesions. One had SSL-like morphology and other 4 were SSLNOS. They did not do a mismatch repair protein expression, so we cannot make a comparison from their non-IBD counterparts. Next is the traditional serrated adenoma-like lesion. Again, as the name indicates, this is this typically is a polypoid lesion that is seen, and it has shows features that are typical of that of the traditional serrated adenoma that we see in non-IBD patients. It has a villiform architecture with serrations. It shows ectopic crypts, eosinophilic cytoplasm, and elongated hyperchromatic nuclei. And this TSA-like component should represent more than 50% of the lesion. And as you can see in these images A and B, you can see a nice villus architecture. The cells have eosinophilic cytoplasm, and you can see the ectopic crypts, which are crypts within the crypts. This is another example where you can see that the architecture is slightly changing. In image C, you can see that there is a little bit of cribriforming, which probably indicate that a higher grade lesion is being is developing in this polyp. Again, these lesions are also very rare. The study by Lee showed that they represent only 4% of all non-conventional dysplasias. They only saw 3 cases out of 78 cases that they had. The incidence was slightly higher in the study by Choi et al., where they found 10 cases out of 58. A more detailed study was done by Miller. This is from Australia, where they characterized these TSA-like lesions in IBD patients. And they found that, 11 of their 52 lesions had high-grade dysplasia, and they found 8 cases with synchronous advanced lesions. And they also did molecular testing, and they found that KRAS mutations are the dominant mutations in this type of lesions. They saw it in 29 of their 52 cases. BRAF mutations were seen in only 8 cases. So TSA that we usually see in non-IBD patients, they are seen in the left side of the colon. In this study, they found that although it was majority were in left side, but 40% were still seen on the right side. So this probably indicates that these lesions might be different from the non-IBD TSAs that we see. So we need to do further comparison, further studies that should explore the relationship between these TSA-like lesions and their non-IBD counterparts. So this is the recap of all the lesions that I've discussed. Again, serrated epithelial change is typically invisible. It shows serrations that involves the full thickness of the crypts. The crypts, they lose their perpendicular orientation. The serrations are irregular, and there is inflammation that separates the base of the crypts from the muscularis mucosae. And they lack the features of sessile serrated adenomas and traditional serrated adenomas. The sessile serrated lesion-like and sessile lesion not otherwise specified, typically, they will show some features of sessile serrated adenomas like L-shaped inverted or T-shaped, boot-shaped crypts. And typically, they do not lose their perpendicular growth orientation. And traditional serrated adenoma, as we've seen, the characteristic features are eosinophilic cytoplasm, ectopic crypts, and elongated pencillate hyperchromatic nuclei. So far I've shown you studies that have provided a robust evidence that these lesions have increased risk. But there are studies that have been done that have shown that this link is not that strong. So this was a study by Dr. Ken Batts from our sister hospital in Minneapolis. He's also one of very well-known GI pathologists. So in their study, they actually, one of the limitations of their study is that they included all serrated lesions. They did not, classify into these subtypes. And they showed that after 1 to 4 years of follow-up, the IBD patients with SCC had about 12.8% likelihood of dysplasia, as opposed to IBD patients without SCC that showed only 4.3% likelihood of dysplasia. This difference again was significant on univariate analysis, but on multivariate analysis, it was not significant. And their conclusions were that SCC conveys slightly increased risk of dysplasia, but the risk of developing cancers appear low. Continued surveillance at usual interval is possibly reasonable, and chemoendoscopy, which is one of the advanced techniques, endoscopy techniques, may increase the sensitivity somewhat. So, as you know, so this indicates that this, there's some discrepancy, as to the risk stratification of these lesions. But more and more evidence is coming that, there is high risk of colorectal neoplasia in these lesions. So in conclusion, I would say that distinguishing serrated lesions in the setting of IBD is a challenging task. And also you need to know the patient clinical pathological features. So these lesions are seen in patients who have standing disease greater than 10 years, and they are typically in their 5th or 6th decades. And SCC, as I mentioned, is almost, in most of the cases, it will be an invisible lesion, whereas these SSL-like and TSA-like lesions will have polypoid or will be visible on endoscopy. So to better implement the diagnosis of these entities into our histological reports, we need to, so that it can help it can help in the clinical management of these patients, we need to do studies that should be focused on inter-observer reproducibility or agreement. And these studies actually should correlate also with the molecular findings and should provide evidence of the risk assessment or progression to colorectal carcinoma. And for TSA-like and SSL-like, where you see polypoid lesions, studies need to be done that should explore the relationship between their non-neoplastic counterparts. So again, this is something new, and I just wanted to basically bring it up and that you should have some sort of familiarization with these entities, because if you don't know it, you will not see it. And I would highly encourage you to read this paper by Dr. Elizabeth Montgomery. It's a very nice review that for me was a kind of an eye-opener, because I practice GI pathology a lot. So with this, I will end my talk, and thank you so much for listening. And this is our medical center where I work.
Thank you so much, Dr. Amin. That was definitely an elaborative talk on serrated epithelial changes in inflammatory bowel disease. Next, I invite Dr. Naila Kiani. She is from Aga Khan University Hospital, and she will be discussing FIGO grading of endometrial carcinoma then and now.
I begin in the name of Allah, the most benevolent and merciful. And I want to thank the organizers for giving me this opportunity. I'm just trying to get rid of this little. This is on the screen. Yeah, need to cross that out. So, sure. Okay, so I'm going to talk about FIGO grading of the endometrial cancer, and this talk is a little different. It does not have the hardcore pathology that we practice every day, but it will change our daily practice, and those of us who are more involved with gynecological reporting of especially endometrial tumors, this will make an impact. So, the story begins in 2013, it actually begins earlier, but the publication that you see on the extreme right-hand side of the left-hand side of the screen, that's when the genomic characterization of endometrial cancers was performed, and 4 markers that appeared at that time. Then what you see on the extreme end of the screen is the, I can use the pointer, yeah. Is this particular risk stratification, which was done by the ESCO and ESTRO and ESCP. This is a European organization, and they came up with that we need to perform these set of markers that are highlighted, which is P53, the MSI panel, and POL-E. And then this year, in mid-year of this year, came this landmark paper of FIGO staging, and by the FIGO Cancer Committee on Endometrial Cancer. There is only one pathologist in this group. The rest are all clinical people, so they are gynecologists, essentially, oncological gynecologists. A little bit briefly about how FIGO evolved. What you see at the very top is a very basic FIGO staging that appeared in 1971, but it started even earlier than that in 1958. And most of these staging there's very little input from pathologists, and they were evolved by gynecological oncologists. So in 1988, we had another one in which we had the tumor limited to the endometrium, invading either half, cervical glandular involvement, if you notice, was there, cytology was important, etc. And then we had the third one in 2009, which we use to date. And this had the various parameters, which I will not go through. But the important things that happened in this particular one was that the peritoneal cytology was out. So for cervical involvement, you needed stromal involvement. Glandular involvement was not considered sufficient. And then they were also, the lymph nodes were delineated, whether they were pelvic that were involved or non-pelvic or beyond the pelvis. Similarly, there was grouping of in tumor limited to the endometrium and involving less than half of the endometrium. The key pathological changes that have taken place are at the very top here, which means now they suggest that we have a binary grading system of endometrial cancer. So grade 1 and 2 have been clumped together. And then there was the group of aggressive versus non-aggressive, and the aggressive types are listed on the screen. LVI became very important. Again, whether an LVI in this, according to this recent publication, it should be to be called as extensive. More than 5 vessels should be involved. And I'll talk a little bit more about it towards the end if I have enough time, because my challenge is to complete this talk in 20 minutes. So this is now the new staging and system, and let's spend a little more time on stage 1, where the real changes are in 1 and 2. So in 1, they have 3 stratifications. 1A, in which this non-aggressive type of carcinoma, which is either limited to the polyp or confined to the endometrium. And then, of course, if it is involving less than half, then it is when. And A3 is when we have synchronous tumors, both in the ovary and in the endometrium, and how to tackle. So I will, the next slide, we're going to talk this about in a little more detail. And 1B is when the non-aggressive histological type is involving 50% or more of the myometrium with little LVSI. And lastly, we have the aggressive histological types. And remember, earlier, there was no distinction based upon histology. Now there is a distinction based upon histology, and the aggressive histological types are without any myometrial invasion, only will fall into the stage 1 group, and they will be 1C. Let's talk a little bit about the synchronous low-grade endometrial tumors. When the tumors are limited to one ovary, when there is no LVI or absence of extensive LVI, there is absence of additional metastasis, and the capsule is intact, and less than half of the myometrium is involved, then that was going to be stage 1A3. However, when you do not meet these criteria, then it will become a stage 3 disease. These are mentioned in WHO, so there's not really something new about it, except that now it is imbibed by FIO. So stage 2 is the other one in which, this next one, in which the non-aggressive type, when there is involvement of the cervical stroma, then they will, and substantial LVSI, or aggressive histological types with myometrial. And again, there is a distinction of whether there is presence of cervical stromal invasion and not glandular in this particular stage. Whereas what we were calling 1A or 1B earlier, the aggressive histological types, now with any degree of myometrial invasion, the 50% criteria is not applied here. They fall into this particular stage. So from there we move on to stage 3. And stage 3, we have in which now the disease has moved outside the uterus, and it can involve the uterine serosa, and if once the subserosa is involved, that's also considered to be positive. It could involve the adnexa and or the fallopian tubes. If there is metastasis or direct spread to the vagina or the perimetrium, then also that is going to fall into this particular stage. And pelvic involvement of the pelvic peritoneum. This is something that was not clear in the previous FIGO staging. Lymph nodes, again, sentinel lymph node assessment is given a lot of importance in this staging system, and we use the same cutoff criteria for micro or macro metastasis. And this is the 2 millimeter cutoff. And again, based upon that, there is a distinction of the staging. And stage 4, there is very little change in stage 4 when it actually goes and spreads to the bladder mucosa or to the intestinal mucosa, or there's distant metastasis, then is stage 4. So that is a very quick review of the new FIGO staging. But then what has led to all this and the integration of the genomic, that becomes how that is integrated becomes the next step to understand. So the flow of evaluation of molecular analysis of any endometrial cancer is considered first to do a POL-E, and we will talk about the issues and concerns in this particular facet of the grading system. Then MSI or MMR and P53 and assessment, as well as other parameters that you can use, which I will to ERPR, etc. So essentially, there are 4 things that I've mentioned already. And the classification of endometrial cancers, this is from the original paper in 2013, and you can see these 4 groups, which are at the very top written as POL or ultra-mutated, MSI or hyper-mutated, copy number low or no specific molecular profile, and then of course the last group, which is high copy number high, which is the P53 group. So what is unique? POL-E is one, then is the MSI group, and then is the other one, and then lastly. The most mutations, if you look at the very last dark black line, is you see that there are a lot of mutations occurring in the POL mutated and in the copy number high group. This here actually shows the graph. If I can get my pointer onto the screen. Anyway, I can't do it. But anyway, you can see the blue line at the top. The POL-E have a very good prognosis, and the worst is with the P53 group. So then the story goes on, and this is the 2020 publication, which is the ASCO, ASTRO, ESAP. This is the entire European group, and they developed a risk stratification system. This is a complex chart that you see towards the other end of the screen, which is colored. I will not go through it, but I just want to point out certain things as we go along in this presentation. One thing is that, remember, the stages written on this are based on the old FIGO system. So at times it gets a little confusing now that we have the new FIGO system, because the new came just now. So let's look at in a smaller group of intermediate and high. Here, what is changed? Look at where the stars and the lines are. Essentially, what it is showing you that if you look at stage 1B at the top, where it is low grade and there is LVSI is negative or focal, the stage is intermediate. Whereas in the same group, when there is substantial LVSI, that means more than 5 vessels are, it gets into the high grade. So a lot of histological evidence has now been built into this staging system. And similarly, the grades also change the risk for stratification. And P53 staging is also changes it. So this is another chart from another publication in which they tell you what is the prevalence of various types. So POL is 5 to 15%. The MMR group, which may be unstable, which is actually unstable, is 25 to 30. And then the larger group is the low copy number on SMP with no particular molecular profile. And that's about, in this study, 30 to 40, but it can be as high as 60. And then the P53 group is 5 to 15. The tests that you can use are all listed there. Prognosis, again, as we know, is good for POL-E and worse for the P53 group. This is same thing. It's not. This is before the FIGO. This is a publication by Navina Singh, and who's no longer alive. And you can see the same stages, and these are based upon pathological parameters. This is an interesting, I find this much more easier to understand than the earlier chart that I showed you, which had lots of colors and lots of text on it. Here I want to just point out one thing, and the rest is, it's basically derived from the same. If you look at the very last column, horizontal column saying high risk, you will notice that all stages in histology with P53 abnormality and myometrial invasion are high risk. So P53 plays a very, very important role in the assessment of endometrial cancers now. This is how it is recommended that it should be reported. And so when you write the stage, you will write the stage. M is for the molecular classification that you use. So if this is Pol E mutant and one has the luxury of doing it, then this is going to be stated as so. On the other hand, if you have P53 abnormal, then that is how it is going to be as a subscript written next to the stage. And there is all the other tests are easily done and available in this part of the world also, except for Pol E, which is usually done by Sanger technique. But there are now simpler versions coming with PCR, and I believe that they are far less expensive. Now, the issue is with the Pol E group is that they have very diverse morphology. So they're pure on histological grounds, they are very difficult to identify. And there are certain times that you may not require a Pol E testing, say when there is the PA53 is wild type, there is very early stage disease, LVSI is not seen, because LVSI is very commonly seen with Pol E disease. So in those cases, you may, or one may not decide to do the Pol E testing. And Pol E again is not indicated in stage 4 or stage 3 disease unless there is a need to do so for any clinical reasons. I just would like to take a little bit of time on this particular chart, which tells you in detail as to what tests should be done in the various categories of Pol E, MMR deficient, low copy number, or no specific molecular type, which is NSAP or P53. And let's look at these two groups. In the NSMP group, it is recommended that you do ER-PR. And in the other group, because if you notice, there are treatment options that are linked to it. If in the other group, which is P53 abnormal, it is important that you do HER2, because about 30% or so will be HER2 positive, and they do have then the option of treating these patients and giving them desired maybe benefit. So there's some recent studies which talk of prognostic values, and they've done some publications related to that, but I would like to spend time on subclonal P53 immunostaining in the diagnosis of endometrial cancer molecular subtype. And as you can see in the illustration, what you will have is a wild type, and suddenly you will see intense subcloning. Subclonal staining. And what are the cutoff points? It's 10% is the cutoff point. And these are the patients that are likely to benefit from more aggressive treatment. And this should be recognized in our daily practices as we perform these tests. Also, if it is in the West, these tests are done on biopsy specimens. And because the system is far more channelized and much more sturdy, so what happens is that the center who gets the original curating is likely to get the hysterectomy specimen. In our setup, things are much more variable. So each institution will perhaps, as time goes along, decide as to which way they want to go and do this. So there are some issues and concerns, particularly by the pathology community in US. Europe is pretty much comfortable with it. when I talk of issues and concerns, I am talking of the FIGO grading system. One of the concern is the number of vessels which are considered as extensive LVI involvement. Each group has its own criteria. CAP has 5 vessels, ICCR has 4, ISGIP, which is the International Society for Gynecological Pathologists, and in recent years has evolved as a major recommending body for many of endometrial pathologies, says that you should submit 1 centimeter, 1 section per centimeter of the tumor. And so obviously the tumor size will determine how many sections. So institutions who are more vigorous perhaps will have a different data, whereas other institutions who are not that vigorous in submitting their sampling. Then people are unhappy, the pathologist, with the lumping of the various histological types into one aggressive type. For example, carcinosarcomas and dedifferentiated are all put into one group, but we know that the prognostically carcinosarcomas do better than the dedifferentiated groups, and so on and so forth, and this story goes on. Everybody does not agree with the classification of synchronous ovarian tumors into 1A3 group. And so although there is some blessing from WHO, which is available on this particular tech. The other thing that has evolved is that as people are doing this, there is the multiple testing or multiple classifiers are coming up. Multiple classifiers means that, say, a person has POL-E positive and then that person's tissue is also P53 positive. So what do you do? At the moment, it is thought that it will POL-E that will determine the prognosis. And in MMR, it will again the same story. But there is too little data at this time to say that with certainty. And then, of course, the issue of doing POL-E in countries like ours or other part of the world which are resource limited. So we have to wait till we get something which is more economical and more suitable to our setting. And so that's my last slide. So I kind of have made it through. I was wondering whether I will be able to do it in 20 minutes or not. So this just tells, if you look at the upper half, just tells you how simply we're looking at things, high risk, etc. Whereas you use the second part, which it is labeled as molecular treatment algorithm, you realize that the options available for treatment are manifold and very different. And to the patient, it means a lot if you categorize them in that order, and then if you can treat them appropriately. So what we can do, despite, I know there is a cost attached to it, but then after all, there is a human life also. So ERPR, HER2, and P53, etc., and MSI can easily be done, and we can at least do some part of this new grading system. Although, as I conclude, I must say, in the UK, their association has decided that they will only you do this, they will kind of hold their breath on this thing, and after a year decide as to what to do, because as I have seen some comments that it is a little too early for this classification. But I think it's there to stay because it has the blessing of the clinicians. And I will thank you all for your attention.
Thank you very much. Bismillah ar-Rahman ar-Rahim. First of all, I would like to thank the organizers for inviting me to speak at this August forum. After that very interesting but quite mentally exhaustive lecture, very challenging talk by Dr. Naila as always. So this will be relatively easier. I will be addressing this area of slight confusion in neuroendocrine neoplasia in the breast. I'll start with a few cases. So an 80-year-old female with a hypoechoic suspicious mass and an ultrasound-guided biopsy. And here you can see the lobulated tumor nodules on the left side with some what look like fibrovascular cores, and they are made up of monotonous rounded cells with high NC ratio, as you can appreciate on the right. So Neuroendocrine markers done are very nicely positive on both of these. Both the markers are positive, and this is an adjacent area which is showing invasion in the same tumor. So that's an invasive carcinoma. Also, neuroendocrine markers are positive. This is the situation in which we very commonly apply neuroendocrine markers in breast pathology in our day-to-day practice, and that is to confirm a solid papillary carcinoma. And it may have invasion with a conventional type of breast carcinoma, and that is graded, as we all know. Coming to my second case, this is a 60-year-old female with a suspicious breast lesion again and a core biopsy. And here you can appreciate on the left side, this core, which is not optimally fixed, is showing a very cellular tumor with infiltration into the stroma. And on the right, you can appreciate that these are very hyperchromatic oval cells showing some molding and a diffuse type of chromatin. So if you did neuroendocrine markers like we did, this is a CD56, which is very strongly positive, and a synaptophysin, again, which is positive. So this looks like a small cell carcinoma. And if you do site-specific markers like GATA3, SOX10, they're usually negative. Chi would be very high, just like a small cell carcinoma elsewhere. So in this case, our opinion was small cell carcinoma, as expected, but one must rule out METs from elsewhere when we are faced with such a case, because of course it's a very rare lesion. Having said that, another important point is that in our daily run of cases, when we are very busy, one may overlook the small cell morphology and just call it a conventional invasive breast carcinoma high grade if you're not thinking of it. So although it is rare, it does occur. Case number 3, which was the reason that I chose this topic, was of a 53-year-old female, and we received a mastectomy specimen. There was a history with it that this patient had been diagnosed as a large cell neuroendocrine carcinoma of the breast on a core biopsy at another institution. So we received the mastectomy, and it showed these large sort of jigsaw puzzle type of pieces, but not anastomosing, not very organoid, and there were areas of necrosis in the center of these nests. A higher power view showing somewhat monotonous cells, and they had these round nuclei and a reasonable amount of cytoplasm, and these were the immunohistochemical markers that we did. So synaptophysin was also positive, although variably, and chromogranin was also positive. And this is a GATA3 stain, which was also diffusely positive. So now, what to call this tumor? Should we call this large cell neuroendocrine carcinoma, or should we call it invasive breast carcinoma with neuroendocrine differentiation? Now, if you keep the MDT in mind and the clinician in mind, these two diagnoses may have very different management options for the patient. So this is a very, on top of that, if you're disagreeing with the original report, that in itself raises questions in the MDT. So keeping this thing in view, I selected this topic to look at these neuroendocrine tumors as they relate to breast pathology. We all refer to the WHO, the 5th edition, for our guidelines. In the WHO, there is a unifying concept now of neuroendocrine tumors, which they are trying to use across the board in GI, even in the pituitary, it's PIT, NET now. So similarly, in the breast, the chapter says that on neuroendocrine tumors that you grade them, classify them into NET, grade 1 and grade 2, and neuroendocrine carcinoma, small cell and large cell. When you look at the NET chapter, it says that there are only 2 grades. Mind you, there's no NET grade 3 like there is in the GI. And they are it also says, although it defines them as having diffuse uniform immunoreactivity for neuroendocrine markers, but the same chapter goes on to say that classical features of lung and GI net are not necessarily seen in the breast. So you may not have the typical organoid features of the trabeculae and festoons and ribbons and so on. You may not have the typical nuclear features. And the grading, as I said, G1, G2, G3 is also not applicable. You are supposed to, as it is in the net, and the significance of necrosis is not the same. And you grade them like you grade the typical breast carcinoma. So the Nottingham grade is applied, and they usually fall into grade 1 or 2 out of 3. So how do we confirm that it's a primary of the breast? So if there is DCIS in the vicinity, if there is ER expression, if there are axillary lymph node metastasis, and if there is an absence of history of extramammary tumor elsewhere, then we can think of a primary breast net. On the right, you see this picture is from the WHO of a typical breast net, what it would look like, and the neuroendocrine marker positivity. Of course, the common tumors which we know express neuroendocrine markers in the breast are, as I mentioned to begin with, solid papillary and the hypercellular type of mucinous carcinoma. So you must exclude those whenever we are thinking of a breast neuroendocrine tumor. So this is the practical approach which is proposed in an article, recent article, of if you have such a tumor, first you look for, of course you have the markers are positive, and INSEM is the new marker which we are still getting used to in our department. So if you see intraductal neoplasia, then if you have a typical history, and a point to note is that diarrhea and flushing, these are usually not seen in primary breast net. So if they are there, then one should think of some extra mammary net. And then there are additional site-specific markers which may or may not be of help. Coming to neuroendocrine carcinoma. Now, in this section, WHO says that the small cell is, of course, as we know, very rare, less than 0.1% of all breast cancers. But that means that in every 1,000 cancers, there should be at least one. So we should be on the lookout for it. Because this is treated differently. This goes to platinum-based therapy like in a small cell carcinoma. Large cell, it says, is extremely rare. And the criteria are similar to large cell neuroendocrine carcinoma of the lung, and desirable is that there should be DCIS. So this is a picture from WHO of a large cell neuroendocrine carcinoma, and which on a busy day, I honestly might not get neuroendocrine markers done and might miss it actually. So on the right side, it is showing the chromogranin positivity. So this is the large cell neuroendocrine as shown in the WHO. But if you go to the chapter on invasive breast carcinoma, where of the no special type, where it describes the special patterns, there it says that in addition to the other patterns which we know are now, they're called patterns, oncocytic, lipid-rich, sebaceous, they are all called patterns. So it says that carcinoma with medullary pattern and invasive carcinoma with neuroendocrine differentiation are currently considered to be special morphological patterns of invasive breast carcinoma. And it goes on to say that the 90% rule for special subtype is not applied to tumors with any of these patterns. So this, I personally found this very confusing. So, and it also says that if neuroendocrine histological features or neuroendocrine marker expression are not distinct enough or uniform enough to classify a cancer as NET or neuroendocrine carcinoma, then you should use the term invasive carcinoma, NST with neuroendocrine differentiation. But at the same time, it says that 90% rule does not apply, does not make it a subtype. So you will stay in this category. But then when will you call it a large cell neuroendocrine carcinoma? Will you ever apply that category? all of us being histopathologists, we like to have scores, we like to have numbers to deal with, and that is not given very clearly. So the issues which are uh, in, uh, in this particular area of breast pathology are, number one, there is the issue of histogenesis. There is no normal neuroendocrine cell in the breast like there is in the GIT and everywhere else. So although this is just a theoretical discussion, it may have practical impact, but it's basically people kind of agree that it's more of a differentiation of the tumor stem cell towards neuroendocrine markers and expressing neuroendocrine markers rather than actual histogenesis from a neuroendocrine cell. There is no standardization of neuroendocrine marker use, so all of us use whichever markers we are comfortable with. Some might apply 2, some might apply 3, some might apply 1. How much should be positive? How many cells should be positive? What should be the intensity? Is there any scoring system? So far, I could not find anything like that. There are no cutoff values which are defined. And then what about the mixed tumors? So we are faced with confusion in the realm of diagnostic criteria. This is a paper which was published in May 2022, in October 2022. And this is from Italy, where they studied the diagnostic agreement and impact on outcome in neuroendocrine neoplasms. And they had these 3 groups of experts from 3 different, about 6 hospitals. And there were total number of cases that they studied were 287. And they had very moderate agreement. So only 122 cases actually qualified for the study, the rest were excluded. And in the more than 0.6 is substantial agreement, and in these 3 groups of experts, they could only field a Cohen-Kappa score of 0.4. So even the breast experts, they don't agree on what to call what lesion. So when should we apply neuroendocrine markers? They should not be applied to routine breast tumors in general. And this often happens in our IDC, that someone will come up with the breast markers and we ask the person, why did you put them in the first place? You could just, when you have a cell here and there which is positive, and then you are faced with this question of what to call it. So it should not be routinely applied only if it actually really resembles a neuroendocrine neoplasm. Of course, in solid papillary carcinoma, it has a supportive role. Another area where neuroendocrine markers can help are intraductal papillary lesions, where if there is a suspicion of DCIS or clonality, and if there is a diffuse expression of these markers, it supports DCIS, because normally cells do not express neuroendocrine markers in the breast. The normal epithelium does not express. This is an algorithm which has been proposed by Imad Rakha and his group in one of the recent papers. And this I found very useful. In this, if you have an invasive breast carcinoma with neuroendocrine morphology, either it could fall into the mucinous or solid papillary group on the extreme left. That's fine. Once you've applied neuroendocrine markers, if it's negative, then that will be diagnosed as such. On the right side, if you have a small cell carcinoma, which is nicely positive, you will call it as such and then look for metastasis from somewhere else. Once that is excluded, you can call it a primary small cell carcinoma. Then if it looks like the typical carcinoid tumor, again, you have to rule out the metastasis. And once that is ruled out and you have a DCIS or supportive features, then you can call it a primary. If the middle 2 areas in this chart are very useful. So if the IHC is focal and weak in an invasive breast carcinoma, then you diagnose it as invasive breast carcinoma, NST, and do not mention the neuroendocrine differentiation. And just leave it at that. If it is diffuse and unequivocally positive, then you diagnose it as IBC with neuroendocrine pattern. So, and they say that the large cell neuroendocrine carcinomas the few cases which are called that, they are actually belong to this category. This includes moderate staining or diffuse weak staining, but there should be staining. So in that situation, you call it a pattern and don't call it a large cell neuroendocrine carcinoma, because then that raises a lot of questions as regards the management of these cases. This is my second last slide. So this is about neuroendocrine ductal carcinoma in situ. So that does exist, although we very rarely diagnose it. And it looks, on the left side, the figure shows the solid type of neuroendocrine DCIS, which looks very much like a usual type of ductal hyperplasia, because there are the spindly kind of cells and a swirling appearance. But if you apply neuroendocrine markers, they would be positive. So this should be kept in mind when we are looking at a DCIS or suspecting a DCIS versus a UDH. On the right side is one of our own very recent cases in which we had an invasive cellular mucinous carcinoma, and that had neuroendocrine marker expression in the areas of DCIS which were present adjacent to the tumor. As you can see on the lower right, that is a synaptophysin positivity, and the upper is a duct which is showing the DCIS. And this was actually a mucinous, invasive mucinous carcinoma, cellular type. So the take-home message is that, of course, the bottom line is that all primary neuroendocrine tumors of the breast are very rare, and we must exclude metastasis whenever we are faced with one. And neuroendocrine differentiation is not uncommon in invasive breast carcinoma. So a cell here and there, if it is positive, it should not be included in the reporting, and it should be disregarded. We should not apply neuroendocrine markers unnecessarily, and neuroendocrine differentiation, it can be seen in DCIS, and that establishes clonality. And the last but not the least is that large cell neuroendocrine carcinoma is very rare, and it's a controversial entity to date because the criteria are not well defined and because it has different management implications. So if you stay away from it, it's better, because the patient will be treated along the lines of a conventional invasive breast carcinoma as they should. Thank you very much. These are the references that I have used.
Thank you so much, ma'am. That was an informative talk. I now want to invite Dr. Tariq Sarfraz from Foundation University, Islamabad, and he will be discussing updates on role of immunohistochemistry in ovarian malignancies.
Bismillahirrahmanirrahim. Assalamu alaikum and a good afternoon to everybody. First of all, I am extremely thankful to the organizers for giving me an opportunity to give a talk here at this prestigious forum. So I am really grateful for this opportunity. The topic of my talk is role of immunohistochemistry in ovarian malignancies, and I'll be giving an update in reference to the guidelines from Royal College of Pathologists. These updates may not be very new for my senior colleagues, but the aim of my presentation is that we usually in routine come across some of the difficult scenarios in which we have to take the help of immunohistochemistry, and that is actually there should be a guideline for our working histopathologists as well as for the trainees, because they may come across such type of case in their exam also. So Sir Winston Churchill said that, I mean, to improve is to change, and to be perfect is to change often. So updates keep on coming, and they should be coming like this, because with that you improve the quality of the work as well as your diagnosis and all the things. This will be my sequence of presentation. As it is said that nothing has revolutionized the field of medicine in the last 50 years as it is done by immunohistochemistry. And it has not only given a clarity in our diagnosis, but it has also provided the they help in predicting the prognosis as well as in management. And ovarian malignancies are no exception to that. Ovarian malignancies are one of the, I will say, leading sort of cancers in females, and they are the seventh greatest cause of death worldwide. As far as the general rules of immunohistochemistry are concerned, they apply to the ovarian malignancy also, that the use of immunostain should be as a part of panel. One should know the normal staining pattern and the compartment of the cell, where the cytoplasm or nuclear staining. Internal controls are mandatory, and especially when we are looking for some loss of expression, for example, mismatch repair genes, immunohistochemistry, or null pattern p53 staining. And diagnosis is made in conjunction with the morphology and not only on a single stain. A few more things to be considered are there can be some unexpected positive or negative results. So they must always be interpreted in correlation clinically, radiologically, and along with the morphological features. And the multidisciplinary team approach, discussing these type of cases in multidisciplinary team meeting, is again a very, very important thing for further evaluation and management. I'll restrict my talk mainly to the ovarian carcinomas. I'll not even touching the germ cell tumor, sex cord stromal tumors, because majority of the cases which we face and the difficulty we face in categorizing them, that is of the epithelial ovarian malignancies. And all of us know that there are these 6 common ovarian carcinomas, including the low-grade serous carcinoma, high-grade serous carcinoma, endometrioid carcinoma, mucinous carcinoma, clear cell carcinoma, and carcinosarcoma. Well, this talk, I can assure you that this will be even easier than the previous 3 talks. So there will be few difficult scenarios which we will be facing. And at times, it will be difficult to differentiate between the high-grade carcinomas, especially the high-grade endometrioid carcinoma and high-grade serous carcinoma. And sometime in high-grade serous carcinoma, one finds large areas of clear cell morphology also. So what we should do in this situation? I mean, this is the key. This guideline I have taken from the Royal College guidelines. And here you can see, if you find a diffuse nuclear positivity of WT1 along with p53 mutant, then the diagnosis mainly will be high-grade serous carcinoma. And you can even take the help of p16 also, which will be diffusely positive in high-grade serous carcinoma. On the other hand, ER-PR, I mean, ER sometime it is positive in many of the cases of serous carcinoma, but PR is more important, which will be negative in this case. And as far as high-grade endometrioid carcinoma is concerned, you will find WT1 negativity, and mostly p53 will be wild type. Few cases may be showing the p53 mutant. And as far as p16 is concerned, you will find it to be negative, or they may be patchy positive. But ER-PR, they will be positive here. And as I told you, sometime you find the clear areas also. And in this situation, you have to confirm or rule out the presence of clear cell carcinoma. And you can take the help of all this panel, where WT1 will be negative, p53 will be wild type, p16 will be negative, ER-PR, they will be negative in clear cell, and Nepsin A and HNF1 beta will be positive. So this panel you can use once the difficult situation is like that, once you are finding some high-grade carcinoma and you are not very sure that whether it's a high-grade serous or it's a mixed, or there is high-grade endometrioid or some clear cell is there or not. The second thing which can be helpful, that is the mismatch repair gene immunohistochemistry. This helps in making the diagnosis, predicting the prognosis, and provides opportunities for therapeutic options such as immunotherapy. How we can take the help of MMR immunohistochemistry in differentiating these tumors? All of you know that mismatch repair gene include MLH1, PMS2, MSH2, and MHS6. Absence of expression of one or more. This is important, that once even single is absent or there are more than one absent, this indicates high microsatellite instability, and is corroborative of a diagnosis of endometrioid carcinoma or clear cell carcinoma, but not serous carcinoma. So sometime you can take the help, especially in difficult cases, and you will find that if there is absence of expression of anyone, then you can think that it is not serous carcinoma, it is either endometrioid or clear cell carcinoma. Okay, so this is, whenever you will find the expression, then if all they are expressed, then it is a serous. And even if a single is, there is absence of expression, then it may be endometrioid or clear cell, and then you can take the help of the other markers. Another situation is, once it is difficult to differentiate between low-grade serous carcinoma and high-grade serous carcinoma, what we can do in this situation? Because the management is totally different and we have to give a clear-cut diagnosis. So here you can use this panel. WT1 will be positive in both, whether it's a low grade or high grade. But P53 will be mutant in high grade and it will be wild type in low grade. Similarly, P16 will be showing diffuse positivity in high grade and it will be negative or patchy in low grade serous carcinoma. And as far as Chi67 is concerned, it will be low in low grade serous carcinoma and moderate to high in the high grade serous carcinoma. Okay, then there is another difficulty, that is the mucinous carcinoma, that can be primary versus metastatic. And this is sometimes a difficult scenario, especially intestinal type of primary mucinous ovarian carcinomas have an enteric phenotype and they may express the marker like CK20, CDX2 and CA19-9. And I remember one case was placed in the Royal College exam also, in which it was showing the positivity with CK7, CK20, CDX2, CA19-9, and it was actually overlapping. And they wanted to know that whether you are able to categorize it clearly, whether it's a primary or metastatic. So what we can do in this? This is the panel which can be used in these sort of situations, because sometimes it is quite difficult situation in mucinous carcinomas. And primary mucinous carcinoma, they will be routinely CK7 positive, but I told you that the tumors who will be having the enteric phenotype, they may be showing the CK20 and CDX2 also. So with this panel, we can categorize it being a primary or metastatic. So you can see CK7, CK20, CDX2, CA1 to 5, CEA, CA19-9. DPC is retained in most of the primary mucinous carcinomas of the ovary, and it is lost in like pancreatic adenocarcinoma metastatic. P16 we can also take the help, because P16 will be negative in primary mucinous carcinoma and it will be block positivity, especially in the mucinous carcinoma of endocervical origin. Sometimes they metastasize to the ovaries. And PAX8 is the one which will be very helpful to differentiate between the primary and the metastatic. And SATB2 is also done as a part of the panel to confirm or rule out the possibility of colorectal carcinoma. So this is a panel which can be used, and you may come across the trainees who are undergoing training, you may come across some of the long case which will be of the ovarian mass, and this all sort of panel of immunohistochemistry will be given in your practical exam. Okay, then there is another entity which is the seromucinous carcinoma, which is a relatively disputed entity, and they say that one should try to categorize it into the more established types as endometrioid and low-grade serous. And for example, if you find WT1 positivity, then you have to categorize them into the low-grade serous one. But as far as the P53 and ER are concerned, they may not be helpful, because P53 will be wild type in both and ER will be negative in both of them. CD10 and added 1A may be helpful in diagnosis, and majority of them will be classified into endometrioid carcinoma on morphology and ISC, or rest of them they will be categorized into low-grade serous carcinomas. So this is a summary, or you can say best practice. On the upper line, you can see these are all the different carcinomas, including high-grade serous carcinoma, endometrioid carcinoma, clear cell, seromucinous, then mucinous carcinoma, and metastatic. And on the left line, you can see, all this panel, which first one should try that one should categorize that what is the scenario. whether we are facing some problem with the mucinous carcinoma or some high-grade carcinoma. But as a whole, for example, if you have to apply all of them, then you can use all of them, include PAX 8, very important to differentiate, especially between the primary and metastatic, WT1 for serous, CK7, all of you know the ovarian, CK20 in the lower GI. P53, I told that the mutant type is in high-grade serous carcinomas. And similarly, P16, I told, this is also very important because sometimes it is difficult to differentiate between the high-grade endometrioid and high-grade serous carcinoma. HNF1 beta and Nepsin A, they are the markers for the clear cell carcinomas. So this is a sort of summary which you can use. As a conclusion, I can say immunohistochemistry is a valuable adjunct in diagnosis and differentiating ovarian carcinomas. It is a cost-effective molecular surrogate biomarker, and by the help of this, we can categorize the ovarian carcinomas very clearly. And it is mandatory to apply an ovarian for all the ovarian carcinoma for the exact typing and management. I still remember, Brigadier Sergeant Mushtaq will also be knowing, one of our gynecologists in the army, she was a rank of colonel, and she had an ovarian mass, and at that time immunohistochemistry was not established in Pakistan. This is late 80s, and she was diagnosed as a mucinous carcinoma of ovary. And then the blocks, they were sent to St. Thomas Hospital by the kind courtesy of Brigadier Sajid and General Manzoor, and then they actually told that this is a colorectal carcinoma which has metastasized to the, because she was not getting well, rather her condition was deteriorating. So once the immunohistochemistry was done there at St. Thomas's, they called it a colorectal carcinoma which was metastasized to the ovary. So take home message is that never rely on one immunohistochemistry marker. Unexpected positive or negative reactions can occur, so one should be mentally prepared for that. Results are always interpreted in conjunction with clinical, radiological, and morphological features. And whenever there is any case in which you find this type of difficulty, one should always discuss this in multidisciplinary team meeting for further evaluation and management. I thank you all for your patient listening.
Thank you. I think we have a little bit of time. Maybe if there are any question answers, maybe the first question from Dr. Naila, that this lymphovascular invasion, which is now built in, it's something which is very commonly misdiagnosed, you know, in retraction spaces, and, you know, quite commonly, particularly the trainees, you know, they come up LVI positive, and when you examine, you know, when you usually come to the conclusion that this is not LVI but a retraction or something, some kind of artifact. So giving so much importance to something which is so subjectively and casually, you know, in my experience, in our experience, practiced, you know, the implications, you know, if any, you may comment on.
Yeah, actually, that's a good question, Dr. Shahid. That was something that was addressed very elaborately. I didn't have time to go, and these points were alluded to, because the retraction artifact, the fact that you may miscommunicate or misinterpret LVI. And they are very particular about this, that the criteria that you use should be the same as you are, as pathologists that we are aware of. That is, you need to identify an endothelial lining, the tumor should be attached to the wall, and it should not be just floating there. And then many times we do IHC to confirm if it is really an endothelial lining is present, or is it some certain artifact, and it's a challenging area. The bigger challenge is actually the number of vessels, because 3, 4, 5, every group is thinking differently. So that's another issue that has yet to be resolved. Although, you know, this is the FIGO grading that we use. TNM is yet to come. the individual who is the author of this article published this year, his last name is Berrick, is actually also an editor on the TNM classification. So we will see how this whole thing evolves. There are many issues with this whole thing. And there is, as I said, the American pathologists consider this difficult, the whole thing difficult and impractical. But I think eventually we will all move towards that because they have very powerful data. And what they've shown is people have gone back, applied this data retrospectively and seen how patients could be staged differently and got it. And I didn't include that. I had to cut, my original talk was very long, so I took out that graph, how people were moved from stage 1 to stage 2, and then they were given treatment in cases in which it was possible to do so, and they did perform much better than if they had not been given those options. So, but I take your point, and I know these challenges always remain in pathology. Yeah.
Thank you very much. And a little before I ask the audience, Brigadier Sarfraz, the P16, you mentioned that even in high-grade serous, it is strong and diffuse.
Yes, sir.
Is that correct?
Yes, sir. So, I mean, sir, we can take the help of this marker also to differentiate between high-grade serous carcinoma and high-grade endometrioid carcinoma.
What about if, the high-grade, carcinoma of the cervix?
That is also, actually, sir, they have included this marker into the panel, which actually differentiates between, if, for example, it is there is a possibility that it is coming from the cervix, then our scenario is totally changed. But if it is only, I mean, the endometrial tumor and cervix is okay, then we can take the help of this P16.
Ali, what about, high-grade endometrioid?
Yes, sir.
Is it strong diffuse positive or with P16 or patchy positive?
Patchy positive, and high-grade serous is the one which is diffusely positive with P16.
Even of the endometrium?
Sir.
Okay.
Dr. Shahid, I think you are right. My understanding is the same as yours, Dr. Shahid. P16 is positive, can be positive both in high-grade serous, serous carcinomas of the endometrium. There is no high-grade, there is just one serous, and also high-grade endometrioid of the endometrium.
All right. So in
So
both.
it becomes difficult. It's the ER that separates the two.
All right. Okay. Thank you. Sorry, I have taken much time. Any?
Sir, this was about ovarian. Madam was talking about endometrial. Yes, that is a different thing. We were discussing about the ovarian carcinomas.
Yeah, I mean, sometimes.
Yes, you are right, sir.
They get
At
mixed
times,
up.
I mean,
They get
this
mixed
can
up.
be
Yeah.
a confusion. Yes.
So, Dr. Khalid Amin, a very fascinating, updated talk. Any comments or question? I think the changes we have seen were very subtle. And when I was saying to Dr. Humaira that maybe this is the area where, the subtle dysplasia, which is so subjective that with time, artificial intelligence may be very helpful to, with the machine learning by the experts, those who have written these papers and things like that, that where a firm decision may be made. Otherwise, you always remain a little, until it's unequivocal, high grade. In subtle changes, it becomes very difficult sometimes, and then you become a little diplomatic, like possibility cannot be excluded and things like that, which otherwise means you don't know, you are not sure.
Yeah, I just want to say that these changes are, serrated epithelial changes were actually, they were in the literature before. But only recently, papers have been coming where they have clearly defined the morphological features, and they have actually correlated these features with molecular testing. So there more and more papers are coming, and just to make people aware that these changing are there. I think we all have seen it, but we don't know about these. So that is the reason of my talk also, was to make everyone aware
Right,
of
right.
these subtle changes.
Well, in a seminar, some experts, were talking about artificial intelligence in pathology. So they were saying that obviously this cannot replace pathologists. What will happen that down the road in very few years, there will be pathologists with AI expertise and pathologists without AI expertise. And obviously, those with AI will be smarter and more accurate compared to those who shy away from the AI. Yeah. So I think time is short. So shields, I think.
So we would like to distribute shields among our worthy speakers. Our first speaker was Dr. Khalid Amin. Dr. Naila Kiani. Dr. Nadra Mamoon. And Dr. Tariq Sarfraz. Now I request Brigadier Dr. Sajid Mushtaq to present shield to our worthy co-chair and chair. Dr. Shahid Parvez. And Dr. Humaira Nasir.
and Dr. Anam Khan for moderating the session.
Session 1 comes to an end. Now we will see after a half an hour tea break.